Hello, good morning, everybody. It's my pleasure to welcome you to our satellite session on personalized health. As you see, we're a rather small crowd, so I'd like to keep this morning a bit more interactive than usual. So I'd like to ask the speaker if you feel in your slides going more interactive, feel free to. And also, if you have any questions, please interrupt at any time, because I don't think it makes sense to be very formal if we have such a small group here. I'd like to kick off the meeting by introducing Professor Peter Meier. Peter has been the president of the Swiss Academy of Medical Sciences and is the leading figure behind the Swiss Personalized Health Initiative, which he has been preparing to make it a national initiative and leading the National Steering Board since its initiation 2 years ago. And Peter will give us an overview of what the project is all about and what we're trying to achieve. Peter, please.
Thank you, Thorsten. Actually, it's a nice introduction, but actually we have both working hard to bring this initiative off the ground. Now, I must say thank you for coming, but I understand we have talked a lot about and we don't have yet results of the project, so I give an overview what the initiative really wants to achieve in Switzerland. You know there are a lot of international initiatives with respect to personalized health and personalized medicine or precision medicine. There are several names and people discuss about the nomenclature, which I think we can leave. But any nomenclature, any name means the same, be it precision medicine, P4 medicine, or individual medicine, personalized medicine, and so on. We call it personalized health because we want to have the healthy people also included. Now, what do we want to achieve? You know that the concept behind personalized health or personalized medicine is the integration of molecular data, molecular profiles of the patients together with the clinical phenotypes, as long as they are patients and there are diseases. This is the holistic concept of personalized medicine. If we talk about healthy individuals, then we want also have the health data included. As everybody of us collects a lot of health data every day, one can use these data and integrate them together with the lifestyle of the patient and other health data to improve prevention of disease and to improve health. Now, the Personalized Health Initiative wants to achieve a nationwide interoperability of all health data and biomedical information. So we want to achieve that in Switzerland the data can be exchanged and shared. That needs some development of infrastructure. As you know, Switzerland is a heterogeneous country with respect to the health system. We have a federalistic system. Each canton is independent and autonomous with respect to his health system. And that has led to different development in different university hospitals, for instance, or cantonal hospitals. So there is no way we are far away of, for instance, what Sweden and Denmark or Netherlands has achieved to have a national personalized health system or with electronic patient records. The IT system or KISS, the systems in our hospitals are all different or almost all different, and it's very difficult to connect them and to exchange data between the various institutions. And that's actually what we want to achieve. And there is a cluster in the Lac Léman region which works closely together now and has organized itself with respect to personalized exchange of personalized health data. And there is a cluster in the German part of Switzerland between Basel and Zurich. These clusters function quite well at the moment. And they have started about 2 years ago. Now what we have to achieve in addition is that both clusters coming closer, even closer, and that whole Switzerland is one system, one data exchange system. And here we have to achieve data interoperability and exchangeability on a national level. This is what the federal government expects from the whole initiative. There are, as you know, many difficult things to achieve. We have to harmonize the ethical, legal, and social implications between all the institutions and through Switzerland. We have to achieve a semantic interoperability, which is not here yet. If, for instance, we just would like to collect data such as weight or height of the Swiss patients, it's very difficult. Every hospital has his IT system. We could not easily just know what is the average weight of a Swiss patient in the hospitals. So we have to harmonize the semantics. We have to see that all the data security is maintained and can be achieved, and that the data can be safely exchanged. And for this, the whole initiative has received around 70 million. This is the SPHN initiative together with the Swiss Institute of Bioinformatics, and here we have an additional project, that's the Biomed IT. I think Thorsten will talk about that, and together this money shall be used or must be used to achieve interoperability and data exchangeability. There's another initiative at the ETH with 50 million who is focused more on the technologies to develop the interoperability between basic research labs and the hospitals, the clinical data. And actually the biggest problem we have are the clinical data, the clinical phenotypes, to standardize them, to harmonize them, and to connect them with the research data. We do not have a national health system where somebody on the top can say the whole country uses this system to connect all the data. As I said already, we are a federalistic country and have to build the whole thing from bottom up. What we want, and what is the goal, is a decentralized approach. We have the institutions. Here we talk about the university hospitals, because now at the moment the initiative includes university hospitals, but you have to increase the cantonal hospitals, then the smaller hospitals, and then the family doctors. This is a long way to go, but the data remain at the local institutions, and we have just to build the net and the interoperability, and here we create a data coordination center which is responsible and sees that these data, and has to see that these data can be exchanged safely. I think Thorsten will talk about that afterwards. Projects have started. We have three types of projects. The infrastructure implementation projects. This is something the hospitals have to do. They have to improve their IT systems and to make interoperability and exchange of data possible. They have received money now, 1 million per year. They have signed the collaboration agreement, and they are working on that and have to achieve milestones. So I think, we have until 2020, we have to have a system where all university hospitals can communicate and they collect and exchange clinical and research data of individual patients. We have the infrastructure development projects. These give money. These are projects one can apply for, and here the money is to develop concrete infrastructures for concrete goals that have to be achieved in order to make the data interoperable. And then we have the driver projects. They are based in research. So they are, for instance, some of them are projects together with the ETH, where we have a research group or a technology-oriented group, and they connect with clinical groups, with clinical specialists in order to develop new knowledge, but also new infrastructure. And within driver projects, SPHN supports the infrastructure building. Now, this is just to tell you that all 5 university hospitals have signed to work together to make interoperability of data possible, and that they are willing to exchange data. Now, this is a big word. I mean, it's fine, it has been signed, but I know the problems come in the details and between persons and all that stuff. So they are fighting now, and we will see. We have to be successful. I mean, it's very clear the federal government says if we are not successful, we will not get any money anymore for the next period. So we are working hard to make this a success. Now, infrastructure implementation projects, as I said already in the beginning, we are in this phase here. Infrastructure building and funding is the priority. The infrastructure shall be built at the hospitals, so we have to have harmonized data management infrastructures, so the hospitals can exchange the data, as I said now repeatedly, but it has also to be connected with research institutions. And here is the Biomed IT node Thorsten will talk about, and it has to be possible to exchange or to collaborate between basic research institutions and clinical institutions more effectively. And then here, the personalized health and related technology initiative of the EHS comes into play and plays a role here also to stimulate translational data exchange. Now here just some examples of what kind of projects we have. Christiane will talk about this afterwards, about the e-general consent. It's very important that patients give their consent, that the data can be used for research. And we need a general consent. That means the same consent over whole Switzerland. And in the future, that should be an e-consent, so an electronic consent, which at the moment is not yet possible. But I tell you already, the initiative of the Swiss Academy of Medical Sciences with respect to a general consent, the same general consent, same informed consent around the whole country. It's impossible. People fight for single words, for details which I never thought that is possible. So it's there, pre-final form, and in the pre-final form it lies around now since a year, and it does not progress. So maybe at a certain time we will then progress, but it's a little bit disappointing sometimes, these things in Switzerland. But we have to be very patient, and in the long run, I think it will come. So there are other projects, infrastructural projects, like harmonizing the data in the pediatric field, and so on. Then the driver projects, they were it was pretty surprising because they were distributed through wide areas of medicine, not only oncology. Here we have the targeted therapy since many years already. You will hear about that from Olivier, but we have also projects in the geriatric field, and we have projects in the infection disease field. So the driver projects cover a wide, several disciplines, which is very good. That means personalized health and personalized medicine developed all over the disciplines in medicine. Now we have the call this year, the second call, and here we have some focal areas. We want to have imaging technologies or radiology data that they can be exchanged between all hospitals, which obviously is not so easy technologically, and people are working on that. But if we cannot exchange imaging data between the various institutions, then we are not fit for personalized medicine. Then the public health area is a focus because we want to include the healthy citizens to improve prevention of disease. Then the cohorts. As you know, we have dozens of cohorts. I think about 45 disease cohorts in Switzerland, and they are all in silos. They are all independent. And we have to connect, we have to make sure that the data, the cohort data, can be exchanged. Because if you have, for instance, a cardiovascular cohort, there are patients, they are often elderly patients, they have other problems, arthritis or cancer or infections and so on, and we have to be able to share these data and to make the data available from one cohort to the other cohort, which is not possible at the moment. So also here we have to develop new infrastructures. The budget is about 10 million for this round, and we got again 38 projects, which is pretty a lot. 38 already the last time, and 6 projects are together with DTH, and the other ones are on the SPHN projects. And you see here, within the imaging field, we have 5 projects. In the public health field, 3 projects. And with respect to nationwide interoperability of cohorts, 5 projects, and the others are more general, more wide projects. I must say the quality, but that is just an impression because the International Advisory Board has to evaluate these projects. But the impression as we had when we first looked them through is there are some very good projects, again, as last year. And then a lot of projects are rather now again in this isolated silo thinking. And this is not what we want. We want to have horizontal networks, and people have to work together on a nationwide basis. Now the driver projects, as I told already, are based in research areas, and they connect to clinical institutions and to the bedside, to the patients. And we have to make sure that these connections allows a safe exchange and secure exchange of data. And for this, we have this data coordinating center, which is an institution of the Swiss Institute of Bioinformatics. And they have people, and they will make sure that here the right technologies are used to really exchange the data safely. Now there are other activities which we have at the moment. The summer school in Geneva, end of September, which is a big international event with about 80 students and a lot of courses and reveries. It's for the younger people to train them in personalized medicine and personalized health. Then we have the international conference also in Geneva with the Federation, European Federation of Academic Medical Medicine. It's hosted by the Swiss Academy of Medical Sciences. That just shows that we also keep or develop the international contacts, because we cannot do the whole thing in isolation. And if you are interested for further details, just go on the homepage. You always see that there what we plan and what is going on, and what you are interested. You can find probably what you are interested in. I thank you very much. And are there questions?
Thank you, Peter. Do we have questions for Peter on the overall setup of the SPHN initiative?
With respect to access to data, if I understand well, we would like to have. Sure. We would like to have a general consent, which is not yet really on the table. But you did also touch the problem that we would like to have access to former data, to past data, which have not been basically collected under a general consent. How are we dealing with this issue from the legal point of view?
Yeah, that's a daily discussion in the ethical committees because that is really a problem. We solve it that way. We have the Human Research Act. We have to adhere to it, and but we always say patients which are still living and are in care or seen by the doctors, they can fill out the general consent. All university hospitals have a general consent. They are just different. But we would like to have a common version of the general consent. So that's not the problem. The problem is if the patients are dead, if they are somewhere else, and there we have the Article 34, and then the ethical committees can give informed consent in place of the patients. But if the conditions fulfill, if there are a lot of patients or they are dead, and then we can use all the data too and can integrate them into the data bank. I think it's now working very well. The praxis has been established. At the beginning there were a lot of discussions, but at the moment we don't have any problem anymore.
Hi, very well laid out, so I think I understand the concept, and I've always been thinking about it from a kind of research angle. To what extent will this setup also enable exchange of information for patient treatment, right? So if I'm going to a different hospital, will the information flow freely, access to images and so on? Is that part of the agenda? Or, okay. Or no?
There's a separate, maybe I can comment on that. There's a separate initiative going on in the e-health sector.
Okay.
I think it's for the camera. So there's a separate initiative on e-health which deals exactly with electronic compatibility of patient records for treatment purposes. And this happens in parallel. At the moment, these are two different initiatives. But of course, we have people on both sides of the aisle. So what we're making sure is whatever standards we're implementing for research, they should be the same that are implemented for care. Because what we want to avoid is what we see in many other countries, and that's divergence of the standards used in the two systems. And then one uses CDISC, the other one uses SNOMED, and then nothing fits together. So here, it's a small country, and there's a lot of people. So we have e-health people sitting in our boards. They have research people sitting in their boards, and we're trying also, it's two different processes, to keep them aligned and converging over time.
Thank you.
Okay. There's no more questions.